Hi, everybody. My name is Josh Ofman. I'm the Chief Medical Officer and Head of External Affairs for GRAIL. It's a pleasure to be here today. And before I go into the presentation, I want to just thank the Prevent Cancer Foundation, not just for hosting this virtual dialogue, but also for their leadership generally in improving outcomes for cancer patients. So GRAIL is a company that was founded about 5 years ago to tackle one of healthcare's greatest challenges. How can we detect more cancer early when it's potentially curable? And we're focused on saving lives by trying to bend the cancer mortality curve. So we've assembled a world's leading team of data scientists, genomic engineers, software engineers, public health experts, and physicians to really tackle this unmet need, which is that most cancers go detected until it's too late. They're often diagnosed in their late stages when cancer is most lethal and where treatments are least effective. So we've developed and pioneered a multi-cancer early detection test that looks at genomic signals in the blood and has the ability to detect over 50 different types of cancer, 45 of which have no recommended screening tests in the United States today. And we do so with a very low false positive rate. And I'll show you those data in a moment. So we think the impact here as a public health intervention could be dramatic and maybe one of the best chances we have at bending the mortality curve in cancer. Because what we know is that late-stage cancer detection is deadly. If you look at the top row across all cancers, you see that if cancer is detected in its late metastatic state, only about 2 of 10 people will live 5 or more years. Whereas if cancer is detected earlier in its localized state, about 9 of 10 people will live 5 or more years. And the deadliest cancer of all is lung cancer, and you see the difference here in very stark relief. If cancer is found in its localized state, over half will live 5 or more years. Whereas if it's detected in its metastatic state, very, very few people will live 5 or more years. So dramatic opportunity to improve outcomes through early detection. And you see that here on this slide as well, looking across all of these different cancers, from breast, where we have screening tests, to esophageal, liver, and pancreas, where we don't. You see that when cancer is detected in its early stage, the 5-year mortality rate is much lower than when it's detected in stage 4 or distant metastatic state. And even for cancers that we do screen for today, while they're saving lives and they're amazing tests, we are still diagnosing too many of them in their late stages. And that's illustrated here on this slide. If you look at the right side of this slide, cancers with no or limited screening, including lung, you see that most cancers are still detected too late in their metastatic state. And on the left side of the slide, in blue, you see cancers that we do screen for. And even when we do screen for them, we're still diagnosing many in their late stages. And this is because of not imperfect compliance with screening, but also no test is perfect. So there are cancers that are missed and many false positives that are found as well. So this is the picture that GRAIL is focused on changing, and changing in a rather dramatic way. So what we have to remind ourselves of is that while single cancer screening tests are doing a great job and they're saving lives, the majority of cancer deaths, in fact, 71% of cancer deaths, are still occurring due to cancers that we are not screening for at all. So the majority of deaths are occurring in cancers with no recommended screening tests. And this is a picture that now we have the technology to change. The technology is here today to be able to detect cancer early in people who have no idea that they have cancer. And so we need to find ways of advancing that technology. And one of the ideas behind a multi-cancer early detection test is illustrated on this slide. when any of us go for one of our single cancer screening tests, colon cancer screening, breast cancer screening, cervical cancer screening, lung cancer screening, we are far more likely in that year to be diagnosed with a completely different cancer. For example, when I went for my colorectal cancer screening 5 years ago, I was 10 times more likely in that same year to be diagnosed with a cancer other than colon cancer. So this is the idea, the big idea of multi-cancer early detection. Instead of just screening for individual cancers, in addition to that, we can now screen individuals for cancer. Because unfortunately, I don't get to choose the cancer that I'm going to get. So I need to be able to screen for all of these different types of cancer. And that's the big shift that we have the opportunity to make by introducing multi-cancer early detection testing. And the reason we're able to even be here talking about this today is because of the amazing convergence of technological innovation that's occurred over the last 2 decades. On the left, you see we've had enormous advances in machine learning and artificial intelligence. And you combine that with the tremendous advances in genomic technology and sequencing technology, along with the dramatic reduction in the costs of sequencing the genome. That is why we're able to sit here today. And technology like this has powered GRAIL's approach. In fact, GRAIL's technology platform is a combination of sequencing the DNA that we see circulating in the blood, combined with machine learning algorithms to predict cancer signals in the blood. And this is the basis of GRAIL's technological foundation and our Gallery test, which is our early detection technology test. So GRAIL's approach has been first to create an atlas of DNA signals in the blood for cancer. So we believe we have the largest data set today of methylation signals in cancer and non-cancer. And we've used that database to train machine learning algorithms how to decipher a cancer signal from a non-cancer signal by looking at methylation patterns of DNA in the blood. We used a very biologically motivated machine learning to discover these patterns and to be able to find the signal from all the noise that exists in the blood. And then we validated this technology using large data sets in clinical settings and have really discovered that we could have exceptional performance that could drive adoption of this type of technology. So what is the GRAIL technology exactly? So when cancer is growing in the body, cells are turning over very rapidly and releasing little fragments of DNA into the blood. So we're able to get this DNA from the plasma and actually find the cell-free DNA that's circulating in the plasma. And we interrogated the different ways of looking at DNA. We compared in a research study the 3 most important ways of looking at the genome. We looked at mutations, we looked at chromosomal alterations, and we looked at methylation patterns. And what is methylation? Methylation are modifications to the DNA using with these chemicals, these methyl groups that attach to the DNA, and they impact gene regulation. So they turn genes on and turn genes off. They don't change the code of the DNA, which is why they're called epigenetic. So the chemical modifications of these methyl groups to the DNA. And we know that in cancer, there are many parts of the genome that are hypermethylated and hypomethylated. And so this is a well-known phenomenon associated with cancer. So our R&D program was to compare these methods. And what we learned was that methylation was far and away the strongest signal for detecting cancer in the body. And when you added chromosomal changes or mutations to methylation, it didn't add to the performance. So GRAIL moved forward with a methylation-based assay and has now validated this assay in one of the largest validation studies done around a diagnostic or a screening test in cancer. Our original validation was published last year in the Annals of Oncology, and the latest data are presented here. So these are the findings from the Circulating Cell-Free Genome Atlas study, and it was our third sub-study of an independent validation set. And what we were able to find in this study was that we could detect over 50 different types of cancer, and to do so with an incredibly low false positive rate of 0.5%. Now, the most important clinical measure in cancer screening is what we call positive predictive value. And what that means is among those who have a positive screening test, what is the likelihood that they have cancer? And we found it was 44%. And just to put that in context, the positive predictive value for a mammogram is about 5%. The positive predictive value for a low-dose CT scan in a smoker looking for lung cancer is about 3 to 5%. And the positive predictive value of a stool-based colon cancer screening test is similarly somewhere between 4 and 6%. So this is just a dramatically improved positive predictive value. It's never been seen before in cancer screening. And in terms of detection, we had a pre-specified analysis looking for early stage cancer, stage 1 through 3, of 12 cancers that we know account for about 2/3 of cancer mortality in this country. And we were able to find almost 70% of those cancers. Truly remarkable. When we opened the aperture to look for early stage cancers in all 50 cancers, our sensitivity was about 41%, because now we're including cancers, some of which we know don't shed a lot of DNA into the blood. But I'll share with you in a minute why it's still important to look for those. And then when there was a cancer in the body, we were able to correctly predict where in the body it was almost 90% of the time. So our test reports a cancer signal detected and where in the body we think that cancer is, which is critically important to help the physician guide their workup to look for that cancer signal. And to go a little deeper into the performance here, again, looking at all cancers, you see our sensitivity across all stages of about 51%. If you look at solid cancers without common screening options, you see the sensitivity approached 65% now. So this is truly remarkable to look for all those other cancers that we're not currently screening for. So the idea of a technology like this, Gallery, our multi-cancer early detection test, is that we can detect most cancers, cannot detect all cancers, because not all cancers have access to the blood, and not all cancers shed DNA into the blood. The idea here is to complement, not to replace, the recommended single cancer screening tests. Those screening tests, as I've mentioned, have shown the ability to improve survival or reduce mortality for these single cancers. So we need to add to them because they're not detecting enough cancer in the population. So the goal here is to optimize overall cancer detection in the population. It is a public health test. And if we can do that while minimizing harms, in other words, keeping a very low false positive rate, we think we have an enormous opportunity to improve public health. And this is what I mean. If you look at the population between the ages of 50 and 80, this is an elevated risk population. Being over the age of 50, you have about a 12 times higher incidence of cancer than being below 50. And in that population, there's about 1.3 million cancers detected every year. So I asked the question, how are we doing finding those cancers? And when you look at the third bar here, the 5 recommended single cancer screening tests, you see that we're only detecting 15 to 16% of those cancers, a little over 200,000 of them every year, when you include their compliance and their performance. And so you can see that, that is not enough cancers that we're finding in the population to really make a dent in the overall cancer mortality curve. Now, if you look at the far right bar and you were to add our multi-cancer early detection test Gallery to that, and everybody took it, you could see we could now detect almost 50% of all the cancers in that population. And so that's just a dramatic change. So this is the idea about how we can really address the public health unmet need here by dramatically improving the cancer detection rate in the population. And our hypothesis is that if we can dramatically improve the CDR, the cancer detection rate, at earlier stages, that we could really have an impact on the cancer mortality curve. And if we can do it safely, that's the most important idea. So on this slide, you see in the gold bars, of the 200,000 cancers that are detected by current recommended screening tests today, to do that, to find those 200,000 cancers, on the right panel, you see we generate about 8.7 million false positives. So we spend about $25 million a year in this, $25 billion a year in this country every year on cancer screening. But you can see that a lot of that money is being spent working up these false positive results. So if you were to add GRAIL, GRAIL's MultiCancer early detection, to this, you could find another 447,000 cancers, and on the right, see only pay a small penalty in additional false positives. So this is what we mean by improving the cancer detection rate while minimizing harms. And if you were to do this, you could see that the cost to find cancer drops dramatically. It drops from close to $90,000 to find a cancer, given all the diagnostic evaluation that's necessary, to about $30,000 to find a cancer, because the signal to noise ratio is now much improved. And as it relates to the cost of treatment, we know that treating late-stage metastatic cancer is much more costly than treating early-stage cancer. Here on the left panel, you see the total healthcare costs of early versus late cancer in the pancreas. And on the right slide, you see by stage the costs associated with treating stage 1 breast, colorectal, and lung cancer compared to stage 4 metastatic cancer. Dramatically lower costs. So there's great opportunity both to improve outcomes for individuals, but also to lower spending associated with cancer treatment. And what would this do to the death rate associated with cancer? So on the left panel here, we built an epidemiological model of cancer progression. And in the gray bar, you see how cancer is detected today. Most cancers are detected in their late metastatic stage, stage 3 and stage 4. Stage 4 being late metastatic state. And we modeled that if you introduced Gallery, our multi-cancer early detection test, into this population, you could intercept about 70% of the cancers at an earlier stage. And that's represented here in the green. In fact, over time, you could reverse this picture and detect most cancers at their earlier localized state, where they're more treatable and more curable. And if you were to intercept 70% of those cancers at an earlier stage, what would happen to the death rate? And that's on the right panel. Of those expected to die in the next 5 years, we could avert about 39% of those deaths. And just to put that in perspective, that equates to about 100,000 deaths averted every year. That's about the number of deaths averted due to everything we're doing to combat cancer today. Drugs, radiation, surgery, all the healthcare costs, everything we're throwing at cancer today is producing about 100,000 deaths averted every year. So we have an opportunity just by introducing multi-cancer early detection tests to dramatically change this picture and improve public health. So in Medicare, we know that this is a population that has the greatest unmet need here around early cancer detection. There are 62 million Americans covered by Medicare, and that's expected to reach about 80 million people over the next decade. And we know that being a senior over the age of 65 is a very elevated risk group for cancer. In fact, being over the age of 65 compared to being under the age of 65 puts you at about a 7 times higher risk of developing cancer. And we know that about 72% of all the cancer deaths in this country occur in those over the age of 65. So we can see here from these numbers that a multi-cancer early detection test could potentially be very transformational for Medicare and the whole Medicare population around diagnosis and treatment. And I hope you're all aware that in Medicare fee-for-service, there is no coverage pathway for multi-cancer early detection testing or screening tests generally. And very individual screening tests have gotten legislation in order to screen. So the fact that Medicare pays for mammograms or colorectal cancer screening is due to very specific legislation that has enabled this. And so, the Prevent Cancer Foundation, along with many other advocacy leaders across the country, including congressional leaders, are now advancing the Medicare Multi-Cancer Early Detection Screening Act of 2021. And this idea is to provide Medicare coverage for this innovative technology that is coming. We have technology today that can find cancer in Medicare beneficiaries who have no idea that they have cancer. And so we need to find ways of advancing this technology and providing access for those most in need, like Medicare beneficiaries. So thanks to groups like Prevent Cancer Foundation and congressional members who see the value of doing this, there's now a movement afoot to bring this type of technology to Medicare beneficiaries as part of a broader movement to modernize Medicare more generally. And so with that, I'll conclude my remarks, and I'd be happy to take any questions. Thank you very much.
There's some questions here that are coming in. I'm going to jump in if you don't mind. Some of the questions that seem to be most prevalent here are around, number one, when you might expect the Gallery test to be available. And then sort of a build off of that, what does access look like in the initial stages, and how will it be accessible to people?
Yeah, thank you, Matt. So we expect Gallery to be available commercially in Q2 of this year, probably towards the latter half of it. And initially it's going to be available in 3 channels because it's going to take some time for adoption to take place, utilization to grow, commercial coverage to come around, and then we've already mentioned some of the realities around Medicare coverage and payment. So that will take a little bit of time, but initially it'll be available through health system partnerships that we have, through large self-insured employers that will be providing the test to their employees, and then through specific medical practices that are contracted with us to provide the test. So that's kind of the initial rollout, and then obviously we'll expand from there.
Thank you. One of the things that someone didn't hear in your presentation was once people begin getting this test, and it's a complement to existing screenings, can you talk a little bit about the expected frequency that would be recommended for a screening like this?
Yeah, it's a great question. I didn't really touch on it in the talk. I think, based on everything we know about the way cancer progresses, and I think I mentioned that we have developed an epidemiological model of cancer progression. Some cancers move very quickly, other cancers grow more slowly, but on average, we think that an annual use of the Gallery test is the right way to go right now. We will learn much more over the next several years, but today, based on our best estimates of the progression rates of cancers and expert advice we've gotten about that, including some expert panels, we think an annual Gallery test is the best way to optimize cancer detection in the population.
Going back to the access and coverage a little bit, one of the common comments here is more of an expression of concern around the expected coverage from payers in this space. You touched a little bit on Medicare, but also private payers. Could you talk a little bit about the sorts of conversations or how you folks are how GRAIL is handling those sorts of considerations as you bring this screening test to market?
Yeah, I mean, I think there's a lot of excitement about Galleri and multi-cancer early detection, but it is a brand new paradigm. There's never been a multi-cancer detection test in the market. Doctors have not used it. So I think, the commercial payers are, we're beginning to have those conversations now, and I think they're going to progress once the product is actually being used by doctors with their patients, and we have more real-world evidence that is available to the payer for the payers to see. We have a lot of data that are coming out this year in conferences coming up this month and next month, and more data will be shared publicly. And I think we're gonna accelerate our conversations, obviously, with commercial payers. And I do expect that there will be some leading commercial payers that are more innovation focused and tend to be on the leading edge of adoption of technology that will be interested. And we'll have those conversations. And then as utilization continues to pick up, I think the payers will get more interested in providing that type of benefit to those who are using their insurance.
The other question that comes up frequently as well, while working on obtaining Medicare coverage, working with the private payers, working with those customers, initial customers that you talked about, the obvious question that comes up is one around cost and what people could have an expectation for a screening test like this at the outset.
Yeah, so I think, the most important thing to remember is that, there's always going to be a focus on new technology and what the technology costs. But what we can't lose sight of is the enormous human and economic impact that is being exacted by cancer today. Cancer is going to be the leading killer of men and women worldwide. We're spending hundreds of billions of dollars every year on cancer therapies, which are largely in late stage cancer with pretty minimal impacts on life expectancy and survival. And so, and as I mentioned in the talk, 25 billion in screening, where a lot of that money is being spent on false positives. So, what we can't lose sight of is that we are suffering in a public health crisis right now around cancer, and the economic toll and the human toll is enormous. So yes, a new technological innovation like Galleri is going to cost some money. Very different than other genomic tests today, which are in the several thousands of dollars a test. This is going to be, well below $1,000 initially, and then we have line of sight to getting the cost of that test down even more over time as we get into more versioning of the test. So I think that we are going to spend some money, but the investment is a very high value. Our initial estimates that are in the process of getting published are that this is a very cost-effective intervention and a very wise use of healthcare dollars in terms of the magnitude of health benefits that you're buying. So, high-value intervention to be sure, on the order of what other single cancer screening tests are, and we've already decided to pay for those. And relative to the massive economic and human toll that cancer is taking, it's quite manageable.
Shifting gears a little bit, one of the questions that came in, I think, is a really good one. Is could you talk a little bit about the impact that we've seen in clinical trial recruitment and participation as Galleri's been developed?
So as I think I mentioned, we have one of the largest programs in human genomics that we are aware of. we have enrolled some of the largest studies. So our original foundational study is called the Circulating Cell-Free Genome Atlas, which allowed us to really understand which way we should go in terms of developing our technology and how to interrogate the genome in the blood. And it was a 15,000 person case control study, the largest by far that we're aware of. We've also enrolled large observational cohort studies, well over 100,000 individuals. And we've done the first interventional trial using a validated and locked test in over 6,500 individuals at 6 centers around the country. And then we're investing in a very large real-world evidence program that was announced both in the UK and that we are going to move forward with in the US as well. So, you know, the experience base with our technology is going to be very large. And the interventional study, where this was used in the real world in 6 of the leading healthcare centers across the country, we saw the impact on patients, the impact on providers, the satisfaction with the test, and the performance of the test in the real world. And we're very excited, and that'll all be shared at the ASCO meeting later in the month.
Thank you, Dr. Ofman. One of the questions that came up is you had suggested that this would potentially be the sort of an annual test or screening that people would have. Starting at what age? How are we thinking about that?
Yeah, so, you know, right now the Galleri should be used in a population that is an elevated risk for cancer. And, you know, adults, such as a good example of a population like that are adults over the age of 50. Turns out when you carefully look at the epidemiology of cancer, adults over the age of 50 compared to those below the age of 50 are at about 12 times higher incidence of cancer. And then it goes up dramatically after that. So if you're a Medicare beneficiary over the age of 65, you're even at much greater risk than those over the age of 50. So than a 50-year-old, for example. So elevated risk populations are where we want this test to be used. Other groups that we know to be elevated risk but haven't really been quantified carefully for risk of any cancer are obviously smokers, those with strong family history of cancer, cancer survivors, and patients with multiple risk factors like diabetes and obesity. So there are other groups that are obviously elevated risk. We're awaiting some more quantifiable data from those groups about their risk of any cancer in a multi-cancer setting, because most risk factors have been studied for one individual cancer. So those are some examples of elevated risk groups. But really, right now, we're looking at the best example being those adults over the age of 50.
Got it. Another question here is about the 50 types of cancer. And the question was about a specific cancer, and let's all broaden a little bit, which is, can you talk about the performance of this sort of test in a population related to cancers that may be more deadly than ones that are indolent? Is there any tuning of Galleri, if you will, to try to focus on those that are most likely to kill you?
Yeah, no, it's a fantastic question. And it really relates to how our technology actually works. So here's some really important information. The way our test works is we look at DNA that's circulating in the blood, and we are looking at the methylation patterns of that DNA, which are these epigenetic changes that happen that turn genes on and off and are highly associated with cancer. These patterns are subjected to machine learning algorithms that can identify a cancer pattern relative to a non-cancer pattern. And those cancer patterns are very similar across many different types of cancer, which is different than how other tests work. We're looking for breast cancer mutations or colon cancer mutations. That is not how our test works. We're looking at these cancer patterns that are common across cancers. And then once we detect a cancer signal, we then put it through another machine learning algorithm that can predict where in the body is that signal coming from. And because we're looking at DNA in the blood, it turns out that these indolent cancers, examples might be thyroid cancers, slow-growing indolent thyroid cancers, or encapsulated slow-growing prostate cancers that don't kill people. those actually don't shed a lot of DNA into the blood. So it turns out that when you look at all of our data, our test is much more effective at detecting cancers that are more invasive and more likely to be deadly than the indolent cancers, which are not shedding a lot of DNA into the blood. So we feel very confident that by the virtue of the way we detect cancer, we are not going to contribute to this problem of overdiagnosis. And as you saw with our detection rate, it's very good for the deadliest cancers. So pancreatic cancer, gastric cancer, liver cancer, these head and neck cancer, these really deadly cancers, we detect with pretty high sensitivity, given the very high specificity that we have. And the indolent cancers, we don't detect as well, but we want to include them because the more cancer we detect, the better for the cancer detection rate in the population.
You talked in your presentation about positive predictive value. And for the layperson, they may not really have an appreciation for what that means. Why is it important, if you could build on your presentation a little bit, but why is the notion of, quote, positive predictive value important in the context of a multi-cancer early detection screening? Yeah,
it's a great question. So, what is positive predictive value? What that tells you is not the denominator is all the positive results. So if you get a positive test result, how many of them are going to actually be found to have cancer? And that's really, really important. And the biggest driver of that is the false positive rate. So if you have a test, like mammogram is a good example, the false positive rate is around 11%. It's very high. So of those who have breast cancer, of those who don't have breast cancer, about 11% will be found to have a positive result. When you put that in the population, that results in a positive predictive value of about 5%. That means if you have 100 positive mammograms, only 5 of them are going to be found to have breast cancer. And we accept that, all those false positives, because we know where to look. We know to go look in the breasts with more definitive imaging or with biopsy. And so we know that. But in a multi-cancer context, where we could be one of any 50 cancers, that is unacceptable. So our false positive rate is it's about 0.5%, and our positive predictive value is over 40%. So that's just a very different approach, because if you've got 50 possible cancers, even though we can predict the origin of the cancer, we have to have a much higher positive predictive value and a much lower false positive rate than single cancer screening. Otherwise, we could overwhelm the healthcare system. And that's why we focus our test to have such a low false positive rate, and while doing that, detect as many cancers as we can.
A follow-on question to that here was a little bit more specific on the sensitivity of the performance of the test, wanting to know how does the test perform at various stages in for Gallery.
Yeah, so we try to report our sensitivity for stage 1 through 3 sensitivity, which is earlier stage sensitivity. But even if you look at stage 2 sensitivity for the 12 deadliest cancers, stage 2 cancers are localized. Most are curable with surgery and radiation, and very treatable. And we detect almost 70% of those cancers, which is really remarkable for the 12 deadliest cancers that are pre-specified. Obviously, when you look at all 50 cancers or more, that number comes down. But really, for the deadliest cancers, that is incredible detection at stage 2.
At a very high level, we've had a couple of questions about folks wanting to know what that patient experience would be like. How does the test at a very high level get administered, and how do they get the results? How does that signal of origin work? Can you opine on that a little bit?
Sure. So patient will be talking to their physician or their provider about all the screening that they need to do and the single cancer screening tests. And if the physician believes this individual could benefit from Gallery's MultiCancer early detection test, they'll have a conversation about it. It's a simple blood draw. We collect 2 tubes of blood. So, when the patient is coming for their annual blood test or their wellness check, or they're showing up for their screening for a single cancer, it's a very opportune time to draw that blood. The blood then gets shipped to a single laboratory at GRAIL, where we process the sample in about 7 to 10 days. And a very simple report goes back to the doctor. It'll either say cancer signal not detected, therefore this individual should continue diligently doing their single cancer screening test and take Gallery again next year. Or it'll come back and say cancer signal detected, and the predicted origin of that signal is liver or stomach or head and neck or uterus or ovary or some signal detection prediction about where in the body it is. And then the doctors typically know what to go do. They'll either order the appropriate imaging test for that signal origin prediction. And then if a cancer is diagnosed, they'll get referred and treated for that cancer. Some physicians may refer the workup as well, but we're not seeing a lot of that right now. So it's actually a very straightforward process. It's a very simple report. This should be done between the physician and the patient, shared decision-making between them about how to proceed. And that's what we saw. And we saw very high satisfaction in our studies between patients and physicians. And the workup actually getting to diagnostic resolution happened reasonably quickly, even during COVID, which surprised us.
Next question, sort of, what you've described as the role that multi-cancer early detection screening tests can play in the context of existing screenings today. How do we think that maybe other screening tests that are more individually focused, how do you distinguish between what may come about that is more specific to certain cancers versus a sort of a pan-cancer approach?
Yeah, I mean, we think they're very complementary. There are a lot of single cancer screening tests that are in development today. Multiple blood companies are working on better blood tests for colon cancer, for example. There are small companies working on liver cancer, esophageal cancer, ovarian cancer. It's unclear whether those are going to have great test performance when they really are tested properly. But even if they did, there's no competition really. Basically, putting an individual through all of these single cancer tests is going to cost an enormous amount of money and put the patient through a lot. And the cumulative false positives are going to dramatically accumulate in the individuals. Right now, today, for example, if you're a woman undergoing cervical cancer screening, breast cancer screening, colon cancer screening, and lung cancer screening because you're a smoker, your cumulative false positive rate is well over 40% a year. That's enormous. So if you then added 7 more single cancer screening tests, that's just going to go up dramatically. So that's why a multi-cancer early detection test as a way to complement the guideline recommended screening tests for single cancers that have shown to improve survival is really an important idea. They should complement one another. But I think the jury is out about whether 10 or 12 additional single cancer screening tests is going to be affordable, have appropriate levels of performance, or just exacerbate the problem of all these cumulative false positives. We just don't know.
Dr. Ofman, last question. How can folks who are participating here today be helpful with some of the work that obviously the multi-cancer early detection community is going to do to make this sort of technology broadly available to patients and their doctors?
Well, I think, again, I want to thank the Prevent Cancer Foundation for organizing this event and for all of you for attending it. I think what's really important is that, we have technology available today that can find over 50 different types of cancer in elevated risk individuals who have no idea that they have cancer. And that's a very, very powerful tool. in our fight in the war against cancer. And you've heard President Biden talk frequently about the desire to wipe cancer out and change the face of cancer as we know it today. We think Gallery and GRAIL's technology can be a really important part of that war, that new front in the war on cancer. And so making sure that our vulnerable patients in rural communities, underserved communities have access to the test is going to be completely critical to addressing the population health crisis that we're in around cancer. And that means that commercial payers and Medicare need to accelerate the way they're thinking about covering this type of novel, innovative technology. Waiting 10 years for government-sponsored, 100,000 to 1 million individual survival studies is not going to address the problem that we're staring into right now. And we have technology today that's well validated that can do this. So we're going to continue to generate the right evidence, but I think it's up for us to make sure that Medicare has the ability to provide coverage, which means legislation that's been introduced already. If that were to get enacted, that would provide Medicare the opportunity to cover this type of screening test, and commercial payers need to provide this type of access so that we can really have the public impact that we need to.
Thank you, Dr. Ofman. That will end our session.
Thank you, everybody.